Today we talk about esophageal cancer. The outline. We talk about one anatomy, types of esophageal cancer, clinical manifestation, diagnostic workup, treatment, and post-operative complications. First, the anatomy. Esophagus can divide into 4 parts. The cervical esophagus begins from the below the cricopharyngeal muscle at cervical 6th level and ends at the thoracic inlet. The distance from incisors is 15 to 20 centimeters. Upper thoracic part is beginning from the thoracic inlet and ends at the inferior azygos arch. The distance from incisors is 20 to 25 centimeters. And middle thoracic is beginning from inferior azygos arch and ends at the inferior pulmonary vein. The distance from incisors is 25 to 30 centimeters. And the lower thoracic and abdominal part is beginning from the inferior pulmonary vein and ends at the cardia of stomach at T11 level, more than 30 centimeters distance from incisors. An esophagus has 3 narrowings. The superior most narrowing is located at the adenomic border of the pharynx and paroxysmal esophagus. The second narrowing is located at the crossing of the left mainstem bronchus and the aortic arch. And the most inferior narrowing is located at the diaphragmatic hiatus. Esophageal carcinomas anatomy. The esophagus is a 2-layer mucosa-lined muscular tube that journeys through the neck, chest, and abdomen, and rests unobstructively in the posterior mediastinum. It commences at the base of the pharynx at cervical 6 and terminates in the abdomen, where it joins the cardia of the stomach at T11. The cervical anatomy. The cervical esophagus begins below the cricopharyngeal muscle, and it appears as a continuation of the inferior constrictor muscle of the pharynx. A space between the right and left inferior constrictor muscles, posteriorly just above the cricopharyngeal muscle is the site where a Zenker's diverticulum develops. The triangular areas of the sparse muscle cover are shown in the scan. Zenker's diverticulum arises from Killian's triangle. The surgical approach to the cervical esophagus may be from either side of the neck through an incision along the median border of the sternocleidomastoid muscle. The left-sided approach is preferred to avoid injury to the right recurrent nerve. The thoracic portion of the esophagus is approximately 20 centimeters long. It starts at the thoracic inlet in the upper portion of the thorax. Is closely related to the posterior wall of the trachea. This close relationship is responsible for the early spread of cancer of the upper esophagus into the trachea. The lower thoracic esophagus is buttressed only by mediastinal pleura on the left, making this portion the weakest and most common site of perforation in Bohel's syndrome. The abdominal portion of the esophagus is approximately 2 centimeters long and includes as a part of the LES. The histology. The esophageal muscle is inner circular and outer longitudinal. All the muscle fibers are actually helical, outer loose helix and inner tight helix, and not all smooth muscle. about the esophageal histology, there are 4 layers: a mucosa, submucosa, muscularis externa, and adventitia. Metastasis. In the advanced pathologic stage of the disease, direct extension through the wall of the esophagus is common. As a lymphatic metastasis were found in about 60% of patients undergoing esophagectomy. Intraesophageal spread, proximal resection margin, submucosal lymphatic spread occurs often and may result in tumor emboli, producing satellite nodules. 2. Direct extension. Tumor may invade adjacent structures, including the pleura, trachea, left mainstem bronchus, pericardium, great vessels, thorax duct, and the anterior ligament of the vertebral column. The upper esophagus, the recurrent laryngeal nerves may be invaded, and the low esophagus, diaphragm, stomach, and the liver. 3. Lymphatic spread. The upper third of the esophagus drains primarily to the upper mediastinum and neck, and the lower esophagus flows to the abdomen. 4. Distant metastatic disease. Visceral metastasis may be present in up to 30% of patients at the time of diagnosis and a manifestation of advanced disease. Metastases were found in the lung, liver, pleura, bone, kidneys, and adrenal glands. The esophageal veins. Esophageal veins distribute of tumor emboli and link between lymphatic and arterial systems. There are 2 routes. Esophageal vein drain into supra-vena cava via azygos and hemiazygos. Esophageal vein drain into portal vein via branches of left gastric vein. The esophageal cancer epidemiology. This is about the epidemiology of the esophageal cancer. Our China is 160 per 100,000 people. Table 1 is about geographic regions with high incidence of esophageal cancer according to esophageal cancer cell type. Squamous cell, China 21, South America is 13, and Western Europe is 11, etc. And table 2 is risk factors according to esophageal cancer cell type. Squamous cell's risk factors: low income, alcohol, smoking, diet, etc. And adenocarcinoma's risk factors: buried esophagus, obesity, alcohol, and smoking. And about etiology, the carcinogen reasons how is about tobacco, alcohol, nitrosamines, fungal toxins, and spices. And there are others about nutritional deficiencies, physical factors, predisposing factors. For the pathology, esophageal carcinoma is originated from the epithelium between pharynx and the junctional area of esophagus and stomach. Mostly occurs in the middle segment. It's about 52.7%. The early stage circumscribed within mucosal or submucosal layer. There are 4 types: the occult type, erosive type, plaque, and papillary. The advanced stage means the tumor invading muscular or adventitia layer. There are 5 types. Medullary is 60%, fungoid, ulcerative, constrictive, and intracavity. This table is about classification of esophageal tumors. The epithelial tumors, malignant epithelial tumors is mostly the squamous cell carcinoma, then adenocarcinoma of the esophagus. There are non-epithelial tumors like lymphoma, sarcoma, and some benign tumors. There are some common symptoms of esophageal cancer presentation. The symptom onset is late. Progressive dysphagia is most common, initially with meat, then soft food and liquid. Pain develops late, often at substernal, epigastric, or back areas. Increases with swelling may radiate. Weight loss and regurgitation of blood-flecked esophageal contents. Anorexia, fatigue. If tumor is in upper third of esophagus, may have sore throat, choking, and hoarseness. About the diagnostic workup, endoscopy with biopsy is necessary for definitive diagnosis. The location of the lesion, degree of obstruction, and longitudinal as well as circumferential extent of the lesion can be determined. Endoscopic ultrasonography is an important tool to staging. It is important in the evaluation of possible tracheal or bronchial invasion via carcinoma in the cervical and upper or middle third of the thoracic esophagus. Barium swallow with fluoroscopy is the most commonly used contrast agent for fluoroscopic examination of the esophagus and the gastrointestinal tract. It permits a safe, expanded study of the esophageal mucosa, luminal distensibility, motility, and any anatomic pathology. Bronchoscopic examination detect involvement of lung. Computed tomography is used to determine the local extent of the tumor, the relationship to adjacent structures, and distant metastasis. Magnetic resonance imaging, the ability of MRI to demonstrate a tumor in the coronal and sagittal planes is superior in the estimation of the tumor length, but this information has only limited clinical value. This is the TNM staging about the esophageal cancer. T1 means tumor invades lamina propria or submucosa. T2 means it invades muscularis propria. T3 means it invades adventitia. And T4 means it invades adjacent structures. About the treatment, endoscopic mucosal resection. This mainly used in the carcinoma in situ. And the types of esophageal resection may be open or minimal invasive. Sweep esophagectomy is left thoracic or left thoraco-abdominal esophagectomy. Eva Lewis esophagectomy is laparotomy and preparation of gastric or colon conduit, plus right thoracotomy for esophageal mobilization and resection with mediastinal lymph dissection. Malcolm esophagectomy is Eva Lewis esophagectomy plus neck, transhiatal esophagectomy. Dr. Frank Turek is credited with the first transthoracic esophageal resection and performed in 1930. Dr. Richard Sweet, he developed the basis for the modern approach to transthoracic esophagectomies in 1940s and 1950s. Ira Lewis, a British surgeon who performed the two-stage esophagectomy via abdominal approach and subsequent right thoracotomy that bears his name today. This abdominal exposure in Ira Lewis esophagectomy. These incisions of midline and right thoracotomy. This dissection of gastrohepatic ligament toward the esophageal hiatus and dividing the openum and short gastric vessel and dividing the right gastroepiploic vessels. Neckline or planned gastric resection and insert a jejunostomy tube 30 to 40 centimeters distal to ligamental trace. This is about divide azygos vein. Patient is placed in the left lateral decubitus position, prepared and dropped a right posterolateral thoracotomy incision is made, and the fifth intercostal space is entered. The lung is deflated using the double lung in endobronchial tube, placed at the beginning of the anesthesia. The azygos vein is divided using the endo-GI. The pleura is scored with the electrocautery from posterior to the azygos down to the hiatus. The inferior ligament is incised, and the pleura scored back to the cut azygos vein boundaries. Boundaries of dissection are not marked. The esophagus is then dissected and encircled with a large Penrose drain. Using the Penrose as a traction device, the esophagus and attached lymphalveolar tissue are embolized from the mediastinal bag. Aortic branches are clipped. The dissection includes mobilization of the subcarinal lymphoid packet, which is kept intact with the specimen and marked with a double stitch. The pericardium is bare. The vagal nerve trunks are cut as the esophagus is mobilized from the lower superior mediastinum. Once the hiatus is reached, final attachments are released. Level 15 lymphodes are carefully identified and resected. The nasogastric tube that was placed after the endoscopy is withdrawn to the thoracic inlet. The esophagus is stacked up above the azygos vein using a GI stapler with a green load. With care to preserve proper orientation, the stomach is delivered through the hiatus into the chest. The gastric conduit is formed by several applications of ILA 100 mm stapler, or use the 60 mm endo stapler. The previously cleared portion of the distal lesser curvature serves as a distal marker. The highest point of the fundus is easily identified when the stomach is put on stretch. If tumor is at the gastroesophageal junction, A more V-shaped stapler line will increase the radial gastric margin. The point of the stapler line is oversewn with the 3/0 silk horizontal matrix suture as well as real stapler lines. This is the anastomosis. This is a diaphragmatic approach through a circumferential incision. The perioperative complications, esophageal cancer. First is anastomotic leak. The incidence of the intrathoracic leak following Ava-Lewis esophagectomy is typically 5 to 10%. An intrathoracic leak is a life-threatening event that usually requires immediate operative intervention. Two is anastomotic stricture. Anastomotic stricture is never life-threatening. A large retrospective meta-analysis concludes that the incidence of symptomatic stricture was somewhat higher following anastomosis in the cervical position, is 28%. Then after Ava-Lewis resection, is 16%. 3 is recurrent laryngeal nerve injury. And 4, respiratory complications. The incidence of pneumonia following esophagectomy range from 2% to 47%. Respiratory failure following esophagectomy occurs in 4% of patients. 5 is bleeding, bile leak, post-restriction reflux, impaired conduit emptying, and local recurrence. Review questions about esophageal cancer. What is the diagnostic workup for patients presenting with esophageal symptoms? The A is history and physical examination. B is upper gastrointestinal series. And C is upper endoscopy with biopsies of all concerned luminous structures. And D is computed tomography, scan of chest and abdomen to define nodal and potential metastatic disease. E is endoscopic ultrasound to define the T stage of the primary mass and the regional lymph node inlet with possible fine needle aspiration biopsy. F is PET scan to define disease. The key points of esophageal cancer. The most common in older patients with dysphagia is 85% of cases, and weight loss 60% of cases. Two major causative factors are alcohol and tobacco. Diagnosis is made by upper GI and endoscopy and biopsy. Most common variant is adenocarcinoma. Second most common is squamous cell cancer. Radiographic workup is necessary to stage disease. We talk about primary mediastinal tumors. Anatomy of mediastinum. It is bordered by upper thoracic outlet, inferior diaphragm, anterior sternum, posterior thoracic vertebrae, and bilateral mediastinal fluid. It contains heart, great vessels, trachea, esophagus, thymus, thoracic duct, lymphatic and fatty tissue, and nerve, etc. The anatomical division of mediastin. There are 3-zone division: the anterior, middle, and posterior. The 5-zone division: anterior superior, posterior superior, anterior inferior, and posterior inferior, and middle. The histology type is uncertain until now. classified as following according to the China Academy of Medicine in 1975. It's about teratoma, thymoma, malignant myeloma, neurogenic tumor, and others, including intrathoracic thyroid, bronchial or esophageal cysts, and pericardial cysts, etc. In the anterior mediastinum, there are teratoma, thymoma, intrathoracic thyroid or parathyroid, etc. In the middle mediastinum, the bronchogenic cyst, pericardial cyst, and lymphoma is common. And posterior mediastinum, the neurofibroma is the most common type. This is a picture of neurogenic tumor. In clinical findings and diagnosis, the teratoma often located in the anterior part and occasional chest discomfort and pain. The X-ray displays precordial clear, round shadow with classified or bony consistency. The neurogenic tumor often located at the posterior part, and symptoms derived from the nerve or spinal cord. The X-ray displays a clear, equal density, round or down-filled shadow at posterior mediastinum, occasionally with dilated intervertebral foramen. And thymoma, often located in the anterior part, and the symptoms myasthenia gravis. X-ray displays clear margin, equal density, round overall shadow at anterior mediastinum. And cystic tumor is often located as the middle or posterior part. The symptoms derived from cystic compression. X-ray displays a round, smooth shadow. The treatment. Surgical resection must be carried out as soon as possible when the diagnosis is confirmed, except lymphatic malignant tumor, which is sensitive to the chemotherapy and radiotherapy. And thank you.